I thank the organizing team led by Dr. Vijay Kumar Bada sir for the kind invite to present before this August Guardian audience on resection and lymphadenectomy in gastric cancers. This would be presented by both myself, Dr. Subrahmanyeshwar Babu, I am a surgical gastroenterologist from Apollo Secunderabad, and my colleague.
I'm Dr. Harish Gautam and surgical gastroenterologist from KIMS Gachibowli.
I would begin the talk with thanking my teachers because of whom I am here. Greetings from Apollo Secunderabad, that's my team. So to start with, the evolution of gastric cancer surgery has seen leaps and bounds of changes. Starting from standard open surgery to laparoscopic techniques, and as we started understanding the disease biology and the technology improvements, then we ventured into robotics, and now we are into function preserving surgeries. Coming to the standard resection procedures based on the tumor locations, be it a proximal stomach or a body of stomach, these cancers as a standardized treatment we prefer to do a total gastrectomy with a D2 lymphadenectomy and total omentectomy, while those tumors in distal stomach are opted for subtotal gastrectomy with D2 lymphadenectomy and partial omentectomy. The proximal margins have been defined by the Japanese guidelines, wherein if the tumor is of expansive growth pattern as in Bowman's type 1 and 2, we go for a 3 centimeter proximal margin, and the other types of tumors, the infiltrative patterns, go for a 5 centimeter margins.
And when coming to the lymphadenectomy part, why lymphadenectomy? We need lymphadenectomy for accurate staging, for the prediction of the loco-regional recurrence, and indirectly or directly we will be knowing the survival benefit post lymphadenectomy. And coming to the Japanese Gastric Cancer Association, we have 16 nodal stations, and we label them N0 to N4 depending on their location and their site from the primary location. Coming to the nodal stations, already I think previous speakers have discussed regarding the nodal stations. 1 to 6 stations are the perigastric station, and coming to the further stations, there are stations along the major arteries which will be labeled from 7 to 16. Not going much into the details of the stations and their labeling. So standard nomenclature for the lymphadenectomy. D1 lymphadenectomy is a more conservative approach where the perigastric lymph nodes are addressed. D1 plus is a lymph node dissection where anything more than D1 lymphadenectomy but not the D2 even if single station more than D1 perigastric nodes have been removed, we'll be labeling them as D1 plus. Coming to the D2 lymphadenectomy, it is more considered as a standard of care, which is along with the D1 lymphadenectomy, we'll do the hepatic, left gastric, celiac, and lymph nodes along the splenic hilum and the splenic artery. And the D3 lymphadenectomy is an extended lymphadenectomy where we also remove the porta and mesenteric lymph nodes. And D4 lymphadenectomy is where we address the para-aortic and the paracolic nodes.